Okay, I think it's time we get started. I appreciate everybody joining us today, and we're very excited today to talk to you about our new program in treatment-resistant depression. So welcome to the Immune Bio's KOL webinar on treatment-resistant depression, or TRD. I'm David Moss, CFO of Immune Bio, and I'll provide our listeners with an outline of today's event before I turn it over to our moderator, Dr. CJ Barnum, who's our head of neuroscience for Immune Bio, who will introduce our very distinguished group of panelists here today. As a reminder, this event is being recorded and will be made available on the company's YouTube channel, which can be found on the company's website a few hours after the close of the discussion. We expect today's TRD XPro1595 webinar will last about an hour, with about 45 minutes of the time allocated to panel discussion and the rest for Q&A. At this time, all attendees have been placed on mute in a listen-only mode. If you would like to ask a question, please use the Q&A button in the Zoom window and type your question in the dialog box. Alternatively, you can email me your question at dmoss@immunebio.com, and I will provide them to the moderator. As a reminder, this conference is being recorded. Before we begin, I remind everyone that except for statements of historical facts, the statements made by management in responses to questions on this conference call are forward-looking statements under the Safe Harbors provision of the Private Securities Litigation Reform Act of 1995. These statements involve risks and uncertainties that can cause actual results to differ materially from those such as forward-looking statements. Please see the forward-looking statements disclaimer on the company's earnings press release, as well as the risk factors in the company's SEC filings, including in our most recent quarterly filing filed with the SEC. There's no assurance of any specific outcome. Undue reliance should not be placed on forward-looking statements which speak only as of the date they are made, as the facts and circumstances underlying these forward-looking statements may change. Except as required by law, Immune Bio disclaims any obligation to update these forward-looking statements to reflect future information, events, or circumstances. So, with these forward-looking statements behind us, I'd like to introduce you to your moderator, Dr. CJ Barnum. CJ.
Thank you, David, and thanks everyone who is joining today. David, if you could advance to the next slide, please. So I'd like to start with a slide that puts this program that you're going to hear about today into context with the overall company platform. So Immune Bio is a company that is developing therapies to treat the innate immune dysfunction. As this figure depicts, innate immune dysfunction participates in the pathogenesis of many diseases, and our ongoing clinical programs in cancer, Alzheimer's, and coronavirus illustrates the breadth of this problem. Now, thanks to an award from the National Institute of Health, we now add major depression to our clinical programs. Advance the slide, please, David. Major depression is a debilitating disease that is extremely common. Approximately 25 million patients suffer from depression, and it's estimated that 1 out of every 5 people will have a depression episode at some point in their life. Major depression is also one of the leading causes of death and is the leading cause of disability worldwide, but you'll hear more about this shortly. Unfortunately, approximately 7 million patients do not respond to conventional antidepressant therapy. It is the goal of this webinar to provide some context around this problem and why we believe targeting inflammation could provide significant benefit for many of these patients. We are honored to have with us 2 extremely highly regarded thought leaders in this space, and the bios that I'm going to give you will not do them justice. Dr. John Schneider is the CEO and founder of Avalon Health Economics. Dr. Schneider has over 25 years of experience in this area, and his company is a full-service health economics and outcomes research organization with considerable experience in treatment-resistant depression. Dr. Charles Raison is the Mary Sue and Mike Shannon Distinguished Chair for Health Minds, Children and Families at the University of Wisconsin-Madison, among many other places. Dr. Raison is one of the foremost experts on inflammation and depression, and he is uniquely qualified for this discussion, having published the seminal proof of concept study showing the efficacy of anti-TNF treatment for treatment-resistant depressions, a story you'll hear more about later as well. Thank you both for being here today, and we are very much looking forward to your talks. So the agenda for the remainder of this webinar is as follows. Dr. Schneider will give you a presentation on the economics of treatment-resistant depression, followed by Dr. Raison, who will talk about inflammation and the precision treatment of depression. After that, I'll talk a little bit about the clinical trial, and we'll have a Q&A. So with that, I'd like to turn it over to Dr. Schneider. Dr. Schneider, the floor is yours.
Thanks a lot, CJ. Appreciate the introduction, and thank you to everyone who's joined us today from around the world, I guess. You know, originally I was going to go after Chuck, and thankfully, he's a tough act to follow, obviously. So thankfully, I got moved ahead, and I didn't even have to ask for that. So thankful for that. Yeah, there's nothing much more I can add to my bio, except that this has been an area that I've been interested in for a while. I started doing some research at the University of Iowa on sort of organizational factors around MDD. So that's what got me interested in it, and that was about 20 years ago. So I've been doing some work ever since. So, you know, I think CJ already mentioned some of the sort of basic highlights around MDD. And it is about 8% of the population. There's various estimates out there that have it at more than that, and some that have it a little less than that, but that's still quite a high prevalence. And perhaps more importantly, the prevalence of major depressive disorder has been growing, and it's just expected to worsen. There's been some early studies out showing evidence that it's expected to worsen as a result of the pandemic and the resulting recession around the pandemic, largely due to things like stress and job loss and lower wages and things like that. MDD, again, as CJ mentioned, MDD is associated with significant morbidity, mortality, costs, work loss days in the form of absenteeism, and productivity in the form of presenteeism. These are very substantial factors associated with MDD. Now, a substantial proportion of the pharmaceutically treated depression, or PTD, patients do not respond to treatment with 2 or more antidepressant medications despite adequate dose, duration, and adherence to treatment. These cases are generally considered treatment-resistant depression, or TRD. The proportion of MDD/PTD cases that progress to TRD is estimated to be anywhere between 10 and 35%, depending on the study and the definition of TRD. Some estimates are as high as 50%. Meta-analyses that we've conducted show it to be around 13 to 15%. So this is a big problem. You've got these cases that of MDD who are not getting better and progressing to treatment-resistant stage of disease. So TRD. You know, the question that mainly that I'm going to focus on is how expensive is TRD? What are the economics of TRD? In terms of direct and indirect costs, and now this is from Amos et al. I think I can't see the bottom of my slide here, but I think it's a 2018 study. This is a chart that shows TRD, you know, the columns sort of from left to right here are TRD, non-TRD, MDD, and then non-MDD. So the main point here is that you can see the TRD incremental additional cost is significant. It has comparatively high mental health costs as well as non-mental health care costs. That's the sort of reddish shaded figures, red and pink shaded figures are mental health related, and the blue are non-mental health related. So you can see that they're both higher for TRD versus non-TRD MDD, and of course both of those are higher than non-MDD. So the important message here is that we're not just adding mental health care costs, we're adding sort of regular healthcare costs as well when we progress to TRD. And if you go over to the right-hand side of this, the figure, well, I'm sorry, can you go back to the other, yeah, thank you. The right-hand side of this figure shows that TRD also has substantially higher disability costs. So that's the lighter colored, sort of aqua color there. The lighter color is the disability costs, and those are also higher for TRD, substantially higher. Here, next slide. Now, what this shows is, this is a study by Avalon et al. This shows that even within TRD, there are significant differences. So not all TRD is heterogeneous. So in this case, severe TRD is associated with higher, it's mainly higher behavioral related costs than moderate TRD. And both of those are higher, both in terms of behavioral related costs and behavioral related costs compared to the mild TRD. So again, this part of the problem in defining TRD relates to this type of heterogeneity. Next slide. One of the things that's common to TRD is that it's associated with changes in treatment regimen. So, or I should say the cost of TRD is associated with changes in treatment regimens. These are two different studies here. Interestingly, I thought that these studies are use data that are 15 years apart. So the study on the on your left by Russell et al. Shows that the horizontal axis there are number of antidepressant medication regimen changes, and so it goes from 2 to 8. And then the vertical axis is dollars per month. So you can see that there's this linear trend here of costs increasing with regimen changes. So every time you change these, the medication for the treatment-resistant patient, they're incurring more costs on a dollars per month basis. 15 years later, a study by Amos et al., actually the same study that I referenced and discussed above, essentially shows the same thing. And this is number of lines of therapy of adequate dose and duration across the horizontal axis. It goes from 2 to 6+. And then the vertical axis in this case is payments per patient per year, or expenses per patient per year. So again, you can see this linear increase. The advantage of this chart is that we have, well, actually similar to Russell, but in greater detail, the breakdown of non-mental health care related costs and mental health care costs. And once again, we see both of them increasing with regimen changes. Next slide. So what are the main points here? Well, just to run through the main points, TRD is at least twice more costly than MDD. That's what Amos et al. Found, and some other studies that reach similar findings. So 2 times more costly. We also know that more severe TD is more costly than mild TRD. So we have, again, this heterogeneity within TRD in terms of severity. TRD patients who switch regimens more frequently have higher costs than those who stick with a regimen for a longer period of time. So what are some challenges here? There are obviously a lot of them. One is how to define TRD. There's some debate about that. And the other is how to determine which patients are more likely to progress to TRD from an MDD state or progress within TRD from a mild state to a more severe state. Again, the range of patients progressing to TRD is estimated to be essentially between 10 and 50% if you look at the whole range of the literature. Again, it's a big range. So there's likely within TRD a treatment heterogeneity problem. And that's something that could be addressed with biomarkers. If you look at, just to describe what I mean by a heterogeneity problem, one of the things we face in pharmacoeconomics quite often is this idea of treatment heterogeneity. And generally speaking, what it means is that there are some treatments that work better on some types of patients and not so good on other types of patients. And the way to illustrate this is if you look at, this is just a simple diagram. It doesn't pertain to any particular product or drug. What we have here is the treatment effect on the vertical axis, and across the horizontal axis, we have a distribution, sort of a hypothetical distribution of patients. So you can think of the distribution A would be a randomized clinical trial of drug X on all individuals with disease Y. This is sort of your classic RCT, randomized clinical trial design. In the curve labeled B, you have an RCT on of X, drug X on patients with Y disease, but perhaps for only age over 50. So what do we see here going from A to B is that we see a higher treatment effect for the over age 50s. This is sort of what I'm talking about when I mentioned treatment heterogeneity. You've got a bigger, more bang for the buck, if you will, by treating the patients in group B rather than in A. And finally, in group C, again, this is all hypothetical, you can do an RCT of X on Y with specific biomarker of Z. So you have some biomarker that indicates somehow which patients are going to be more responsive to treatment. And when you do that, you can have a greater treatment effect. Now, if you see the note below that says the areas under the curve would be different. So A would be the largest, B would be the next biggest, and then C would be the smallest. So you're getting a larger treatment effect for a potentially smaller segment of the population. Now, that's not always true. You can have a biomarker that doesn't necessarily limit things very much. But generally, that's the idea, is that you're using the biomarker to search for those patients who have the highest treatment response. So this is something that I think could have some value in a condition like TRD. I think that's my last slide. I will pass it on to Dr. Raison, who has a very interesting take on do a deeper dive, I guess, if you will, on TRD.
Yeah, thanks, John. And Chuck, before let me introduce you here. The complexity of the problem and trying to segment these patients, I think, is really important. It's something that's been lacking. And really, Chuck, what I really want to know is, do you have any ideas on how we might do that?
Well, sure. I mean, it's fascinating that the most promising biomarkers by far in depression, which we always think of as sort of a neurological kind of brain disease, are actually markers from the immune system, and that's what we'll talk about. David, you know what? I'm worried that if you give me control, I may not be able to give it back to you. So
okay,
the control with you, and I'll just say next. So anyway, hey guys, folks, it's nice to talk to you. I have spent a lot of time in this space. It's one of the most fascinating and powerful developments that's happened in mental health over the last 15 to 20 years. So inflammation and the precision treatment of depression, let's dive on in if you can hit next. So let's start with a thought experiment. So here we see a gentleman outside of a house, and the question is, does he look like this because he had a girlfriend or a wife in that house that threw him out and he's heartbroken? Or does he look like this because he ate some bad fish and he just threw up in the bushes? And it really highlights something that was really the start of this field, which is, if we can have next, please, that depression and sickness look a lot like each other. This was first actually discovered by Robert Danzer in mice, but you see the same thing in humans. So if you line up what happens to us when we get sick versus what happens to us when we are depressed, the symptoms are largely overlapping, right? So, when you get sick, you lose pleasure in things, you're exhausted, your appetite changes, your sleep changes, you have a hard time thinking, you can feel down. A lot of people feel down, you're tired, you slow down, you just, there's a whole list of them here. Well, it turns out that if you cast an unbiased eye on major depression, you see a lot of the same symptoms. In fact, the overlap is quite striking, even on things that we don't think about as being related to depression. So, the classic symptom of sickness, God knows, as we know now in the age of COVID, is fever. And the reason you get fever and other symptoms when you get something like the flu or COVID, it's not that the virus goes up to the brain and starts tinkering with your machinery. It's that the body's immune system recognizes the virus as something dangerous, activates these inflammatory pathways. They signal the brain to raise your body temperature, to make you tired, to do all these things, to cause sickness, because over evolutionary time, sickness helped you battle infection. So it turns out, for instance, the fever exists because higher body temperatures tend to denature viruses and bacteria, and they also activate the immune system. Well, we always think about depression as being primarily related to interpersonal, sort of social or psychological issues, but there is a robust literature showing that if you take medically healthy people with depression and measure their core body temperature, it is elevated. And if you treat them successfully, their body temperature falls. It's really quite remarkable. So even symptoms like that suggest there's some sort of deep correspondence between sickness, which we know is driven by inflammation, and depression, at least in groups of people. Next slide. Well, so that was actually the initial observation. The next major thing that happened were that a number of us began to realize that there were medical procedures that were being done in the 90s and into the 2000s that could serve as remarkable model systems for understanding in human beings what happens when you take somebody that's not inflamed and artificially inflame them. And the most classic of these model systems was a drug called interferon alpha, which is a cytokine. It's a molecule produced by the body naturally in response to infection, but it was widely used for cancer. It didn't work that well, and more widely used for hepatitis C, where it did work pretty well. But it had this remarkable property that it took people, and when they started taking the interferon, they began to show signs of inflammation. Next slide. And so it was none other than Andy Miller, who you'll hear about, that is my old mentor and colleague at Emory, who's one of the co-investigators on this grant that the company's gotten for XPro, who had the really great idea of looking to see how often do people that are getting interferon alpha go from not depressed at all to really depressed. So he rounded up a bunch of folks that were starting interferon alpha for malignant melanoma. They were not sick. They were not depressed. You can see down is bad on a slide like this, times across the bottom, 12 weeks. And what he found was in this group of, except for having a melanoma that was problematic, but not being sick and not being depressed, by the time 3 months of this chronic inflammatory stimulation from interferon alpha was over, 50% of them had a raging major depression. Now, the reason this paper got into New England Journal of Medicine, though, was that he did something even more interesting, which was 2 weeks before people started the interferon alpha, he started half of them on an SSRI antidepressant, an antidepressant called Paxil, which was widely used, or a placebo, blindly. People didn't know what they were getting. They took that for 2 weeks. They kept taking it, and they started taking the interferon alpha. And what he found was that, if you can hit the next slide, please, or the next thing, that the red line, the people that were pre-treated and stayed on that regular old antidepressant had their rates of depression reduced by a factor of 3, a massive effect. So here is evidence that's been just replicated repeatedly since then, that you take people, you put them under a chronic inflammatory stimulus, they have a real high rate of getting depressed, looks like depression, smells like depression. You treat them with a regular old antidepressant, and boom, you can really attenuate that development. So this really suggests that inflammation is involved somehow in the pathophysiology of depression. So if you can hit next, please. So Andy and I followed up on this in a series of studies with interferon alpha in hepatitis C patients. And this is one of my favorite findings from those studies. We studied these guys up one side, down the other. We brought them in before they started interferon. We measured their sleep. We measured their blood. And here we measured their body's immune response to their first shot of interferon. So they got the shot. We measured their blood levels of cytokines, and in this case, a very important inflammatory mediator within cells called P38 before they got the interferon and for hours and hours afterwards. And this is a really remarkable finding. So we found out that we could almost 100%, with almost 100% accuracy, predict how depressed people were going to be a month later. So after they'd been on interferon alpha for a month, we could accurately predict it by how much P38 they made within the first 6 or 7 hours after the very first dose. So what you can see here is the differences in P38 production over on the left, on top, between people who went on to be depressed getting interferon alpha versus people that went on to get a lot less depressed, even though they were on interferon alpha. The scatter graphs below just show, it's just amazing. The more this inflammatory P38 goes up in the first few hours, the more depression goes up over a month. Now, interestingly, when we looked at P38 a month later, so when we looked at it at exactly the same time spot as the depression ratings, there was no correlation. So this suggests P38, boom, it gets activated right away. It's doing something. So what does P38 do? Well, one of the main things it does is it turns on a cytokine that's directly relevant for the conversation we're having today, called tumor necrosis factor alpha, or TNF. It's one of the great sort of major inflammatory cytokines in the body, along with another one called interleukin-1 beta. So it turns on TNF. Do people that are exposed to this chronic inflammation, do they have elevated TNF when they're getting their interferon alpha? Next one, please. Yes, they do. So the graph on the left shows people treated with interferon alpha that have HCV, hepatitis C, versus a control condition group that did not get interferon alpha, but that had hepatitis C. The purple line is way higher. So across 24 hours, we got blood every hour. The people that had spent a month of receiving interferon alpha had much higher levels of one of its primary receptors that is key for driving its inflammatory signaling. Even more interesting in some ways, if you look at the scatter plots on the right, what they say is that the more your the more your TNF went up in response to interferon alpha, the more exhausted and unhappy you got. So it's a very sweet story. Interferon alpha is a driver of inflammation. It activates some early mechanisms that turn on TNF. The more TNF you get in response to interferon alpha, the more miserable and depressed you are, really suggesting that blocking TNF might have powerful antidepressant effects. Next slide. Well, so what we've said so far is that, if you inflame people on average, especially when the inflammation is chronic, they get depressed. And it's got something to do with activating TNF, because the more that inflammation activates TNF, the more depressed people get. Do depressed people as a group have elevated TNF? And the answer is definitely yes. This is a meta-analysis. When you put studies together, it's very clear that groups of depressed people have increased inflammation. TNF is the third most often replicated immune biomarker that's elevated. The two that are most reliably elevated are CRP, C-reactive protein, and a cytokine called interleukin-6. The reason that they are more often observed is because they circulate at much higher levels in the blood. TNF doesn't get into the blood very much. It's mostly a sort of within cell kind of thing. But nonetheless, there's a signal that is consistent. So groups of depressed people also show elevated TNF, and you can see how the story is beginning to evolve here. But there's a wrinkle, if I can have the next slide. Oh, no, before I get to the wrinkle. So, there's been a lot of talk in the last few years that maybe depression has something to do with the modern world. And it probably does. But there's this idea that, hey, before modernity, everybody was happy and life was a sort of Garden of Eden. Not true. And one of the ways we know it's not true is there's a group of anthropologists from the University of New Mexico who wanted to study our hypothesis that depression had evolved out of sickness, that depression helped people survive infection in ancestral times because it was associated with increased inflammation. So they went down to a group of semi-hunter-gatherers called the Sename in the Amazonian parts of Bolivia. And they looked to see whether there were depressed people. Sure were, and the depressed people were depressed for exactly the same sort of things we get depressed about. They're depressed because his wife left him for the guy in the next hut, that kind of thing, right? They also measured their blood to look at inflammation. And if you can hit next, they found that just like in our world, the depressed people had elevated inflammation. In this case, elevated IL-6 in particular. So it does look like this association between depression and inflammation is not a quirk of the modern world. It's ancient. It's somehow integral to to what depression is. Next slide. But there is a wrinkle, and here it is. So these are actual data from a study of stimulated IL-6. The control group, look at them in orange, and what's interesting is they're all kind of bunched together at a low level. What you see in green are the folks with depression, and look how much more scattered out they are. They have a lot more variation, and there's a whole bunch of them that don't look any different than normal. So if you can hit next, you'll see that there is next. There is a group that we might consider as an inflammatory subgroup that clearly have levels above what you see in the normals. Next. And then there's another group that you might think of as a non-inflammatory group that looks like the normal folks, basically. The reason that the depressed people have increased inflammation is not that every depressed person has a little bit of elevated inflammation. It's that there is a subgroup. There is a group of people within the depressed population that has really, significantly elevated inflammation. Next. Well, so, these findings were available in the mid-2000s, and Andy and I decided to really put our mouth where the money was, or the other way around. If inflammation causes depression, if depressed people have increased inflammation, blocking inflammation should show an antidepressant effect. So how are you going to block inflammation? Well, things like aspirin and ibuprofen, they block inflammation, but they also have all sorts of other effects that might influence either them making people less depressed or more depressed, frankly. So we wanted something that was pure, something that all it did was block one of these key inflammatory cytokines. And we eventually settled on a drug called infliximab, which used to be marketed as Remicade. It is a non-specific TNF-alpha blocker. It's an antibody. It just wipes out TNF in general. So we took people that were medically healthy but had treatment-resistant depression, TRD, just like John was talking about, and we randomized half of them to get 3 infusions of salt water and half of them to get 3 infusions of this very powerful cytokine TNF blocker, infliximab. They got one at start, they got one at 2 weeks, they got one at 6 weeks, and we followed everybody for 12 weeks to show 2 things. First off, to show that if you blocked inflammation as a group, depressed people would do better. And second, that the higher your inflammation was before you started getting the anti-inflammatory TNF blocker, the better of an effect you'd get. Because if inflammation is causing your depression, the higher it is, the better you should respond to blocking it. That just makes sense. So what did we find? Well, this is one of the challenges of depression studies. You know, we were about 2/3 of the way in and we were seeing all these miracle cures. Man, I mean, these people had failed multiple antidepressants and they were saying, oh my God, this is a miracle cure. You know, I'm going back to work. I've never felt better. So we were utterly convinced that we were going to, you know, become world famous as the discoverers of a new general purpose antidepressant agent, because there was no way that salt water could have that kind of effect if you hit it next. When we broke the blind and looked at the data, in fact, we found that salt water had exactly that kind of effect, that in the population as a whole, there was absolutely no difference between infliximab and salt water, and that numerically, in fact, salt water was a little bit better. If you had some oceanfront property, you could invest in seawater, and if you inject it in the right way, you know, it has a powerful effect, speaking to the power of placebo, which also speaks to the need to identify biomarkers for people who are going to have less of a placebo response and more of an active biologic response to your agent. Next slide. Well, so that was our first theory. It's not a general all-purpose antidepressant agent. What about whether people with increased inflammation had a better response? And if you hit next, here the data, we saw this no matter how we cut the data. Here we're just looking at whether people had a response, a clinical response or not to the agent, which is a 50% reduction in their baseline score. Blue is infliximab, orange is placebo. The bars on the right that I've circled are people that have elevated inflammation. You see this effect whether you look at it by C-reactive protein or whether you look at it by TNF, tumor necrosis factor alpha levels beforehand. This is the CRP data. These are the CRP data. And what you can see is that in that group, the blue bar is way better than the orange bar. And it's as much better than the orange bar as regular antidepressants are compared to placebo. So if your inflammation is elevated and you're depressed and you block inflammation, you get a specific antidepressant response. So why were the groups so equal to each other in the entire population? Well, this is also an argument for the specificity of this immune inflammatory blocking effect. Look at the bars over on the left. These, in fact, are the 2/3 of patients that had, you know, lower levels of inflammation. The lower the levels, the less of a benefit they got from infliximab, and the more of a benefit they got from placebo, such that those guys did way better with salt water, and you don't want to block their inflammation. So, you know, look at the orange bars. As your inflammation goes up, your placebo response drops. So there's 2 fascinating things here. It suggests that if you use an inflammatory biomarker and you use a powerful anti-inflammatory agent, not only do you get a specific effect in that elevated inflammation population, but you get less of a placebo response rate, which has been the devil of antidepressant studies, because it tends to wash out specific effects. So it's a perfect marriage in these high inflammation individuals. You win on both counts. Next slide. Well, so this study was replicated, or tried to be replicated, by kind of a super dude, famous dude in our field up in Canada named Roger McIntyre. He took bipolar depression. He replicated our study with one caveat. These are folks in Canada. They're thinner. They're in better shape. He had a harder time finding people with elevated baseline inflammation. So his baseline inflammation was reduced. So he found 2 things. First off, like us, no overall effect. That's the graph over on the left. He did not find an association with the inflammatory biomarker, but again, his numbers were lower to start with. But we know that early life adversity sets people up for inflammation in later life. So as a post hoc analysis, he looked at that. And if you look at the graph on the far right, these are people that got infliximab who did or did not have, or got infliximab or placebo who did or did not have early life physical abuse as kids. And what you can see is that in the population that had early life abuse, there was a big, big benefit for infliximab. But look over in the middle graph, and there you can see at 12 weeks, that same signal that if you didn't have that particular behavioral biomarker, at the end of it, you did better with salt water, with placebo. So again, it's convergent data that is suggesting that there's something about baseline inflammation or other states that index inflammation that can be predictive of who is and who is not going to respond to blocking inflammation with a TNF antagonist. Next slide. And let me just say before I say this slide, I should have added one more slide that I didn't think of until like 30 minutes before talking to you folks. So this finding that some people do better with a cytokine antagonist that blocks TNF and some people do better with salt water is not unique to infliximab or to anti-inflammatory agents. In fact, there are large meta-analyses of regular old SSRI antidepressants like Prozac and Paxil showing that if you look at individual patients, 1/4 of all depressed people who are put on antidepressants do much worse than if you'd given them a sugar pill. But here's the wrinkle. Unlike with TNF antagonists, we have no idea ahead of time who those 25% of people are that are going to be worse off because they got Prozac or Zoloft or Paxil. It's a crapshoot. Whereas in the immune space, it increasingly looks like we can identify those people ahead of time and target them specifically with a treatment. Next, oh, this is the next slide. Oh, I'm sorry, if you can go back. So after we did this study, Andy Miller really dug in. He's done just amazing work showing that not only do depressed people who are healthy and have increased inflammation respond differently to cytokine antagonists, they also have different brain activity. So they have reduction in the pleasure center of their brain, an area called the ventral striatum, compared to people that are just as depressed, but don't have the increased inflammation. And they also have a disconnection between that pleasure center and what's called the ventromedial prefrontal cortex. It's very involved in assessing how you feel, what you want to do with your life, motivation. It fits with the symptom pattern because it also turns out that the other thing inflammation does is it makes people, what the word is anhedonic. They lose pleasure in life. They lose the motivation to do things that make them feel good. That's a depressive symptom, but it's especially represented in people with increased inflammation. So if I can have the last slide real quickly, next. To summarize, inflammatory stimuli, in this case interferon alpha, but others have been used, promote depression in part through increased TNF signaling. So that's how inflammation does it. Groups of depressed individuals show increased TNF and other inflammatory biomarkers, but this results from a subgroup with elevated inflammation. Non-specific TNF antagonism, like we did with infliximab, has no overall benefit in patients with unipolar or bipolar depression, but shows a signal in the subgroup of patients with elevated inflammation or early life adversity, which is associated with increased inflammation. Medically healthy patients with major depressive disorder and increased inflammation show unique changes in brain function and connectivity and tend to demonstrate increased anhedonia. So improved, more specific TNF antagonists may represent novel precision medicine-based treatments for the subgroup of depressed patients with elevated inflammation. This look for precision medicine and psychiatry has been the holy grail. And again, it really looks like that these immune molecules may be our first targets for that kind of approach. So with that, I'll stop. CJ, turn it back to you.
Thanks, Chuck, and thanks, John. And just wonderful presentations. I appreciate both of you being here today. And as you've heard from Dr. Schneider and Raison, there's a desperate need for effective treatments for treatment-resistant depression. And there's considerable mechanistic evidence for targeting TNF. And this trial is the accumulation of more than a decade of research by Dr. Andy Miller and Jennifer Felger at Emory University, who, as Chuck mentioned, are co-authors on the original infliximab study. And as Chuck also mentioned, Drs. Miller and Felger's research has really identified biomarkers to select patients that are not only most likely to respond to anti-TNF treatment, but also biomarkers of treatment response. And this really was the basis of the grant that was submitted to the National Institute of Health. So the study is a phase 2 placebo-controlled blinded study of XPro1595 in patients with treatment-resistant depression and biomarkers of inflammation. This 6-week study will enroll 90 patients at 2 sites, Emory University and the University of Alabama, Birmingham, with site PIs Drs. Miller and Felger at Emory and Dr. Richard Shelton at UAB, who is another expert in inflammation and well-recognized scientist. To be eligible for the study, patients must meet the criteria for treatment-resistant depression. In this case, it's failed 2 courses of antidepressant treatment and have biomarkers of inflammation defined as C-reactive protein greater than 3 milligrams per liter, plus the presence of anhedonia, a symptom of depression that is sensitive to inflammation, and Chuck just described a few moments ago. The primary goal of the study is to improve functional connectivity. So this is the connections that are lost between the striatum and the prefrontal cortex within the reward circuitry, and to reduce biomarkers of inflammation. Clinical effectiveness will also be assessed as secondary and other measures. And the endpoints will be measured at baseline, 2 and 6 weeks. Next slide, please. So while CRP has been used to select patients in the recent past, this really is the first study to our knowledge that combines a biological and behavioral biomarker shown to be sensitive to inflammation to select patients. Another novel element of this study is that we are assessing biological changes in the CNS using non-invasive methods. In the past, this had to be done with cerebrospinal fluid. We have previously shown in our Alzheimer's program that changes in neuroinflammation as measured by MRI is sensitive to XPro1595. This study takes this one step further and will also measure biological changes that occur downstream of inflammation in the functional connectivity. So in particular, we'll assess whether XPro1595 can restore the functional connectivity between 2 areas of the brain that subserve motivation and reward, and determine the extent to which early changes in these biomarkers can predict clinical effectiveness as determined by traditional measures. So with that, I'd like to thank you for your attention, and we will now move to the Q&A session.
Great. Thank you, everybody. And Dr. Raison, I've got 2 questions for you. The question was, how many of the 60 patients had high CRP, and what was the p-value for that subset? This is the infliximab versus placebo. And then the same question, but for the Canadian subset, kind of the number and the p-value. Do you happen to know that by chance?
I don't know the p-value, for which I apologize. I'm getting old. Details don't stay with my brain the way they did before. So you know, there's elevated inflammation and there's elevated inflammation, and this is worth a comment. So, you know, generally like healthy, let's just take CRP. Generally healthy CRP is thought to be below 1. When we started in this work, 3 was felt to be sort of the upper limit of normal if you're don't have cancer or you're not sick, something like that. The cutoff I showed you, we did by thirds, sort of tertiles, and that value was 5. That was the value at which the infliximab began to beat the placebo. That was 30% of this population, so a not insignificant number. But what I didn't show you is that if you plotted each person's response against CRP, there was no dividing line. It just went like this. It just went straight up. I mean, it was like perfectly on the line. It was the most amazing thing. So the lower your CRP, the better you did with placebo. The higher you did, the better you did with the infliximab. Just as a comment, this is not just a cytokine antagonist blocker phenomenon. We've published some very, very large databases showing that if you look at, in this case, say an atypical antipsychotic that's more of a regular antidepressant for bipolar disorder, CRP totally predicts who will respond and who won't. Higher CRP, you get a response. Lower CRP, nothing. It's been shown in antidepressants. It's even been shown in things like omega-3 fatty acids. So it really does look like something that's real. So, you know, in Roger's study, I don't know, and I should know, but I don't. But I know their levels were lower, and I know that he originally was going to have his cutoff. He was trying to recruit people with a CRP of 3, and he dropped it and dropped it and dropped it, and eventually he had a lower concentration. We generally say that the rates of people that are in this elevated subgroup, if you take 3, for instance, as the cutoff, which is reasonable for a lot of these things, depending on the demographics of the place, it's 30 to 40, 45%. It's a reasonable percentage of depressed people.
Thanks,
Great.
Chuck. Well, another question here for you, Chuck, and this really goes back to the slide of sickness behaviors.
Mhm.
Can you talk about the similarities of, Alzheimer's and treatment-resistant depression as it relates to sickness behaviors, and how one might consider sickness behaviors as behavioral biomarkers of underlying inflammation that maybe transgress across all these different disease states? Is that
Yeah.
something that seems reasonable to you?
Yeah. Well, okay. So there's some interesting, yes. So it's clear that inflammation plays a major role in Alzheimer's, and it's clear that people that have depression earlier in life are at greater risk of developing Alzheimer's later in life, unfortunately, for those of us that have had a bout or two. But they are different. Depression has its onset of action early in life. Alzheimer's has it late in life. Alzheimer's is a wear down condition. It really probably is mostly a modern problem, a problem of just this sort of chronic unrestrained inflammation that so bedevils the modern world. Whereas depression, the inflammation seems to be much more related probably to these older evolutionary drives, but to this question of phenotypic or behavioral biomarkers. This is a really important point because, as I understand from Andy, one of the interesting things about the study y'all are doing is that it's not just a biomarker that you're looking at, it's also this measure of anhedonia. And, you can do this thought experiment yourself. Think about the last time you really had the flu. And I bet you that this symptom of anhedonia, when you're really sick, even if you don't feel depressed, you don't want to do stuff, right? I mean, there's just a loss of interest. All you want to do is lay there. And it's not just that you're tired. There's an evolved mandate not to go chasing the pretty girl down the hall or some sort of big thing at work or at sports. No, you need all your energy to just lay still and fight the infection. So the anhedonia in the context of sickness is an adaptive evolved response. It may or may not have been across evolutionary time with depression. But the fact that you see increased anhedonia in people that are depressed with elevated inflammation speaks to it being a transdiagnostic biomarker that you see associated with inflammation. And of course, apathy is just a primary early symptom of Alzheimer's. Depression is also, but apathy is especially striking, and it goes along with the fact that Alzheimer's, especially early in the disorder, is an inflammatory state. So there are those connections.
Yeah, great, thank you. So John, let me ask you a question about how the market would view segmenting patients for TRD with biomarkers. There aren't any products on the market right now that actually do that, use biomarkers. What are your thoughts on how it would be viewed from either both the scientific community and from the payer's point of view?
Yeah, CJ, that's a good question. And we've seen, this is really kind of still in the grand scheme of things, a relatively new thing, and that's companion diagnostics. And we see it most often now in oncology. And what we do see is that payers are embracing companion diagnostics in oncology, but really only ones that work. And by work, I mean, in my last slide, the ones that can identify the population in which the payer is going to get the most bang for the buck. So that's the population of sort of high responders, or at least moderate to high responders. What payers don't want to pay for is a lot of non-response, and actually that's what they're paying for now. They're paying a lot of money, maybe not on a per patient per month basis, because a lot of the existing MDD treatments are generic, but they're still, it adds up very quickly, and certainly the slightly increasing over year prevalence, payers are paying more and more out of pocket for treatments that essentially aren't doing anything, aren't working. So I think there'd be a lot of interest among payers in biomarkers in this area. As Chuck alluded to before, it's sort of the holy grail. I think this is an area that payers would have a lot of interest, yes.
Great, thanks. And Chuck, we've got a question here about the importance of a drug getting across the blood-brain barrier to treat depression. What are your thoughts on that as being a necessary element for success?
Well, so this is interesting. I think we all suspect that something that gets across the blood-brain barrier is going to be more effective because, of course, most of what makes us depressed is in the brain. But what's interesting about infliximab is that, as far as we can tell, it does not cross the blood-brain barrier. And we didn't measure spinal fluid in that original study, but we dug up people that had looked at whether infliximab crossed the blood-brain barrier in things like rheumatoid arthritis, and it really didn't. So one of the interesting twists of that study was it's certainly the world's first demonstration that a drug that doesn't cross the blood-brain barrier can still have antidepressant effects. And of course, it makes sense. The way to think about it is, if inflammation is coursing through your body, what is it trying to tell your brain? It's trying to tell your brain, hey, you're sick. And if you're sick, you need to act like you're sick. And what does that look like? Well, you're down, you're tired, and also, if you're sick, it's telling your brain, hey, you might die. That's a bummer. It's a depressogenic, peripheral signal. You turn off the peripheral inflammatory signal, and the brain, it looks around and goes, oh my goodness, I thought I was going to die, but it's gone. I guess I feel better. But for sure, we increasingly it looks like one of the things that peripheral immune cells do is sometimes cross into the brain, and sometimes pile up against the brain and set inflammatory motion in place there. So having something on the spot in the CNS that would, for instance, dampen down microglial activation, which I think these are these resident macrophage-like immune cells in the brain, something that would dampen that down is going to, we think, be directly relevant. There's other things we could say. I mean, the other thing you want to do, and CJ, you're the expert on this, is the signaling of this TNF inflammatory cytokine is complex. It signals by some pathways that you absolutely need to have to avoid, losing your immune response to infectious agents. It signals by other pathways that seem to have more negative effects, and the blocking of which specifically might provide an antidepressant effect without the risks or the downsides of just randomly, like we did with infliximab, completely blocking TNF. So there's two things at play that are of interest, to the XPro product. One is the fact that it gets into the CNS. The other is that it's much more specific in its targeting of TNF signaling pathways.
Yeah, and this is RJ. Let me jump in, and because a paper came out today in PNAS, which actually studied the effect of stress on the blood-brain barrier, and it shows that one of the things with the stress response is it causes a leaky blood-brain barrier, and it causes that by decreasing the expression of Claudin-5, which is one of the tight junction proteins. And it turns out TNF is like the kingpin in this. So peripheral TNF actually does affect the blood-brain barrier to make it leaky. So, the source of the inflammation from the brain can be local in the brain, but also it's actually probably more importantly peripherally, all those other things in our life, whether that be obesity, diabetes, smoking, and living within 300 meters of a highway, that actually make a big difference.
Absolutely.
So Chuck, one question here I'd love to get your thoughts on. I guess it's a couple questions related to drug addiction. So so one of the questions here is, many drug addicts have both symptoms of depression and anxiety, bipolar. Does anxiety have a relationship with inflammation as well as depression? And if it does, would you expect an anti-inflammatory anti-TNF like XPro to be potentially effective?
Yeah, sure. So in fact, when we looked at anxiety items on the rating scale that we used, that's called the Hamilton Depression Rating Scale, we saw that infliximab reduced anxiety in that high inflammation group. There's a couple of anxiety items. The 10,000-foot view is that inflammation is not specific to depression, and so one of the exciting things about targeted anti-inflammatory treatments is that they likely are going to have a number of transdiagnostic benefits, which you've kind of mentioned in the beginning, I think, David. But so if you make a list of disorders, psychiatric disorders associated with increased inflammation, it's pretty much everything. In fact, levels of inflammation may be more relevant and are probably higher in schizophrenia than they are in major depression. It's a more catastrophic illness. The same thing with bipolar disorder. So schizophrenia, bipolar disorder, generalized anxiety disorder, post-traumatic stress disorder, a number of studies showing that inflammation is elevated, and that in fact, if you immediately respond to the stressor that's going to give you PTSD with increased inflammation, a month later, you're more likely to have PTSD. So it probably drives those sort of stress, those maladaptive or, problematic stress responses. So yeah, inflammation is a general promoter of psychopathology. And so, finding targeted ways to block it are eventually, I think, going to be promising for a range of disorders.
Oh, great, thanks. So another question here is, anhedonia is typically associated with negative symptoms of depression. Any thoughts about looking at this? What are the best endpoints in phase 2 to capture MADRS? So let me take the first part of that.
That's yours.
Chuck, and I'd like to get your thoughts sort of moving forward. So so if we look at our secondary or other endpoints that we're interested from a clinical scales point of view, we're interested in the anhedonia piece of it. It seems to be what's most sensitive from a clinical rating scale with anti-inflammatories. And there's a scale out there called the SHAPS scale that we'll be using to determine that. But really our secondary outcome is going to be a measure of motivation. And that's directly tied to that functional connectivity that Chuck was talking about earlier that Jennifer Felger at Emory University has delineated. So the functional connectivity subserves the reward and mostly motivation. So we've got a motivation task. Now, as you talk about moving forward, what are the relevant scales? Right now, anhedonia in the SHAPS is not an approvable endpoint as far as the FDA is concerned. You have to do something like the MADRS or the HAM-D. And so there have been some studies that have looked at this, and it turns out that in order to meet that need, you just have to change your level of CRP. So if you look at some of the studies that were done by Janssen with the IL-6 receptor antagonist, they at a CRP of 3, they were able to show changes in anhedonia, but at a CRP of 8, they were able to show changes in the MADRS, whereas they weren't able to show changes in the MADRS at a CRP of 3. So we'll have to figure that out, and part of what this study will do is help us determine what that point will be, inflection will be for our therapy. Any other thoughts, Chuck?
No, I think that's right. It's just more data that says the same thing, right? It's really cool. I mean, these agents work in a subgroup of people and they don't work in others. That's nobody's ever heard of this in psychiatry. I mean, we've dreamed of it for 40 years, but it's really, the data are quite, you just see it over and over again.
Yeah, excellent. So I have one more minute here before we wrap up, and there's a few questions as it relates to preclinical data, and we will put that up on the website by tomorrow morning. I'll have links to the preclinical data with depression. We do have preclinical data in drug addiction as well that will address that question. So at that point, time is up. I will turn it over to you, RJ, to wrap it up, and thank you everybody for joining.
So I'm going to pull a little rank here and ask one more question that comes in that I think it's very important. And I don't know whether this is John's or Chuck's question, but I will quote the question: is TRD like hypertension in that compliance is a big factor, Can we get, do you believe that patients with, treatment-resistant depression will accept an injectable drug? And I'll remind you, this is a once-a-week sub-Q injection, like a interferon shot or like an insulin shot. So I'll throw it out to both of you.
I'll toss in the simple observation that they were willing to accept brain surgery, right? So I mean,
right.
the list was long of people that were willing to have their cranium taken off and electrodes put in their head. They'll accept boxes in their chest to stimulate their vagus nerve. They'll accept ECT, multiple seizures while they're knocked out. They'll accept transcranial magnetic stimulation, which takes days and days and days of sitting there, Oh yeah, depression is arguably the most unpleasant state a person can be in. And when you really got depression, it's hell. And so sure, oh yeah, they'll definitely, if something works, they'll definitely accept it.
John?
Yeah, I mean, I would just add to that. I mean, you do see some adherence issues coming in major depressive disorder, but in the TRD group, I think I think at least the evidence I've seen is of the change in treatment regimens. These people are very much trying to find something that works, and that's evidenced in that change in treatment regimen. the discussion.
You know, and just one other quick comment. You know, there's other interesting sort of general purpose antidepressants that are novel. I'm involved in some of that. And for instance, we're running an 80-person study in mostly treatment-resistant depression. For that 80-person study, we have 15,000 people that have filled out the questionnaire to be in the study. It's a huge, huge need.
Okay, well, this has just been fantastic. I want to thank CJ and Doctors Raison and Schneider for their thoughtful presentations and commentary. And I say that today, targeting neuroinflammation to treat treatment-resistant depression moves from the bench to the bedside, albeit this is the first step in a journey. But we believe we will soon put another tool in the clinician's toolbox to battle this vexing disease. In closing, we must thank the NIH or the National Institute of Mental Health and specifically, and the team at Emory who worked hard to get this almost $3 million SBIR grant to allow this study. When I first met Professor Andy Miller in 2012, he was pushing hard at that time to use XPro1595 to move his as a treatment for treatment-resistant depression. That was 8 years ago, and finally today we're at that point where his passion, hard work, and persistence of his team, because he works with a large group of people there at Emory, has gotten us to the point where you will really be able to see if this is a reality for patients with this difficult to treat disease. When you strip it down to the bare bones, we believe this program is about a new age in psychiatry. It will be an age driven by informed decisions based on biomarkers to allow clinicians to match the patient's pathology with the right therapy. This is pretty exciting stuff, and I think Dr. Raison mentioned that was in some ways the holy grail of psychiatry. And I can tell you that we at Immune Bio are delighted to be part of this revolution. So with that, thank you all for your hour of your day. And with that, we'll close the webinar.
Thank you all. Yeah, it's great.